Welcome everyone, my name is Péter Kulyassa and I would like to present you my 6 months progress report. My PhD theme is functional and morphological investigation of complex coronary pathologies, recent modalities. I'm working at the Department of Cardiology in the Semmelweis University. My supervisor is István Ferenc Édes and my SMS is Mari Yang. My vision is the burden of coronary heart disease will be reduced with improved coronary interventions, and my mission, decreasing the need of recurrent revascularization and the rate of complications. I have 2 projects, and first I would like to begin with the drug-coated balloon effectivity in the treatment of early and late drug-eluting stent in-stent restenosis. This is a systematic review and meta-analysis which we started in last September. As known, coronary heart disease affects more than 100 million people worldwide, and in Hungary it's responsible for 35% of deaths. Currently, the most advanced therapy for treating this condition is drug-eluting stent implantation. Though the eluted drug is somewhat protecting from in-stent restenosis, known as ISR, it's still a problem presenting in approximately 10% of the cases. There is no decision about the optimal treatment of these lesions. Mainly, we have 2 options: a new layer of drug-eluting stent as DES and drug-coating balloon DCB. DCB can be the future direction, and it might be not as effective in the early DES-ISR treatment than in the late DES-ISR treatment. Early, we described developing less than in 12 months, and late, more than 12 months from the index procedure. We have the clinical question that does the timing of the drug-eluting stent in-stent restenosis affects the outcomes of DCB treatment. We compare post-PCI patients in which we compare early and late DES-ISR, and we observe a major adverse cardiac events endpoint, which is a composite endpoint containing target lesion revascularization, cardiac death, and myocardial infarction. Also these separately, and also target lesion thrombosis, target vessel revascularization, and late lumen loss. We performed a systematic search in 5 databases. We found 832 articles, and we did the selection in which, based on the title abstract selection, there was 4 eligible articles, and at the full text selection, we had 3. I would like to present you my results. First, the MACE, the major adverse cardiac events, which is the composite endpoint containing target lesion revascularization, cardiac death, and myocardial infarction. On the left side, you can see the early DES-ISR, and on the right side, the late DES-ISR data. Here, we could find out a 1.68 odds ratio, which means that in the early DES-ISR cases, 68% more events happened than in the late DES-ISR. Our second outcome is the target lesion revascularization. In this, we found a 1.71 odds ratio, which means there were 71% more revascularizations in the early DES-ISR group than in the late one. Our conclusion is that the meta-analysis managed to find statistically significant difference where the individual trials did not. The limitations were that only 2 studies fit for inclusion criteria in all the endpoints, and no data on several of the outcomes were present. The implication for practice is that if DES-ISR appears earlier than 12 months after the index procedure, worse outcomes should be expected from DCB treatment than in late DES-ISR. And for implication for research, more randomized controlled trials are needed to be performed on the subject of DES-ISR treatment with DCB, with recording the time frame between the index procedure and the following clinical event. My second project is the Rafa, the radial artery puncture hemostasis evaluation. This is a multi-center randomized controlled trial, and we decided to publish the protocol of it. If clinical evidence of coronary artery disease is present, in most of the cases, invasive coronary angiography is needed to be performed. The gold standard for access site is radial artery, and the puncture is performed in huge numbers. Therefore, with little decrease of complications, we could improve patient care a lot. We had the clinical questions that do the novel ketosane and potassium ferrate-based hemostasis devices perform as good by radial artery occlusion, damage, and post-procedural bleeding as the currently used mechanical devices. In this, we compared patients coming for any coronary angiography or PCI in an elective and an acute setting. We compared the ketosane and the potassium ferrate-based hemostasis devices with the gold standard mechanical compression device. And we observed the device-oriented complex endpoint assessed with vascular ultrasound at discharge and at 60 days. Also, the compression time assessment at discharge was made. Our hypothesis is that the novel devices perform as good as the previously used mechanical compression device. We drafted a protocol in which we included patients in the age between 18 and 85, and we made a sample size calculation for a non-inferiority study design with a significance level of 95%, a power of 80%, and a device-oriented complex endpoint around 15%, which was a conservative estimation. We also included potential 10% dropout rate and inferiority margin and rounded the sample size, and we came to the conclusion that 200 patients per arm would be enough in the three arms, which are ketosane-based hemostasis device, potassium ferrate-based hemostasis device, and Terumo-band mechanical compression device. The randomization was 1-1-1 design. We had the outcomes. The primary outcomes were a device-oriented complex endpoint, which included puncture site bleeding, radial artery damage, and radial artery occlusion, with a time frame of 24 hours post-procedure or at hospital discharge and at 60 days. Our secondary outcomes were initial compression time of the hemostasis device, immediately after the hemostasis device application, and overall compression time measured at device removal. So these were my two projects, and I have the luck to say that we already submitted the second one to the Frontiers in Cardiovascular Medicine journal, and we are waiting for reply currently. This is a 6 impact factor Q1 journal in cardiology and cardiovascular medicine. And I would like to end my presentation with a quote from Rousseau: "People who know little are usually great talkers, while men who know much say little." Thank you very much.
Congratulations, important projects that you have here. I have a question regarding your meta-analysis. So I'm just curious regarding this time frame. So regarding this restenosis. So it was based actually, were there prospective trials? As I understand, this cannot be randomized because, of course, it's not ethical to say that some of the patients will be undergo intervention again just before or after 12 months. And actually, I'm just curious, how were these? I mean, of course, there are a lot of differences between the population. I mean, this was, the intervention was performed because restenosis happened. That's the reason why?
Yes, so the intervention was performed because the restenosis happened after the index procedure, and we divided the two groups for patients which the intervention happened in the time frame of 12 months after the index procedure and after 12 months the index procedure. It has the base that most likely they are different in tissue characteristics, the types of restenosis, which is currently not really well known yet, but further studies are needed to assess that question.
Thank you. Just another question regarding this. Are these restenosis significant stenosis? I mean, it causes ischemia?
Yeah, of course. So if we perform an intervention, they are just performed by hemodynamically significant restenosis cases. Yes.
Thank you. Thank you.
I would like to ask you, thank you very much for your presentation, and my question would be, what is actually the rationale in differentiating between early and late restenosis? What would be the difference in the mechanisms of these two? Thank you.
Thank you for your important question. So the difference is the clinical implication of difference to be made is that if we find out that in early this ISR, the restenosis event happens more, then we could try more likely the other option, which is new layer of DES implantation. Of course, if we implant a new layer of drug-eluting stent, it has the risk to have more likely stent thrombosis, which we know is deadly. I think most of the cases like by a patient with severe coronary disease. So, and the other thing is that, of course, we could assess, because they say that maybe, and it's also not really supported yet, so we need further clinical assessment of that, that the tissue characteristics of the early plaques are homogeneous and the late ones are heterogeneous. Of course, we could measure them with optical coherence tomography if one catheter, which we can use one time, would be not 1 million forints currently. So it has the clinical implication to differentiate between the choose method.
Thank you very much. And what do you think, what is the difference in these populations regarding diabetes mellitus type 2? Diabetes mellitus type 2 can influence the restenosis rate. Was there any difference between the late and early population in this respect?
Yes, of course we thought about that we will include a sub-analysis of diabetes mellitus patients, but we found that the patient population is too little to have some results about that, but it's a big influence on the outcomes of the restenosis.
Thank you, Péter.
Thank you.
I got one question considering the Rafa study, and I would like to congratulate you to submit this paper already. What was the enrollment policy of these patients? Were they all comers, or were they only elective cases or acute cases as well? And was there any difference between the medical regimes of these patient populations concerning the dual antiplatelet therapy and the anticoagulation as well, meantime?
Yes, so in the study we involve also the acute and elective cases, and of course the patient inclusion is currently running, and we think that between the antithrombotic regime, including the antiplatelet and the anticoagulant regime of the patients, difference could influence our outcomes, but we don't have yet enough data to assess that currently. But we also will in later.